Thank you, Dr. Alere, for that introduction. Again, my name is Hee Katzman. I'm a first-year ID fellow, and my topic today is on future diagnostics and tuberculosis. So this was actually, thanks to Dr. Carver's recommendation, my book chapter turned into a grand rounds. So we'll start. So the topics for discussion today is we're going to talk a little bit about tuberculosis, and the bulk of my talk is on artificial intelligence and artificial neural network in terms of the detection of tuberculosis bacilli, computer-aided diagnosis on imaging, and predictive analytics on diagnosing pleural effusions and drug discovery, and a little bit of talk on the molecular techniques with a point-of-care technology. So start with a little bit of history, right? So it was actually Dr. Jean-Antoine Villemin in the 1800s who first discovered and talked about the infectious nature of tuberculosis. I know that we all know about Dr. Robert Koch discovering the tubercle bacilli, but he was actually the one, this was a French military surgeon who described the infectious nature 17 years before the discovery made by Dr. Robert Koch. So what he did was, it was very interesting. So he actually noticed that, since he was a military surgeon, he noticed that tuberculosis was more prominent among soldiers and military barracks and like crowded cities. So he did an experiment. So he took a sample of infected tuberculous lung tissue from a cadaver who has passed away within 24 hours. He actually injected them to rabbits. So he got 2 healthy rabbits, injected them. But now actually we know that rabbits are actually innately resistant to MTB. So they don't really get the infection, they don't die of the infection. So he monitored them, and after 3 months he still noticed that the rabbits are still alive. So he actually sacrificed the rabbits to see what is going on. And he did notice that from the blood samples, or potentially it looked like the TB had disseminated, but it didn't actually kill the rabbits. So then moving on, he went on experimenting with other animals like guinea pigs, dogs, and cats. But this time he took samples from tuberculosis infected cows, and which later on led to the discovery of Mycobacterium bovis. And so with all this research, he presented it to the French Academy of Medicine, and initially it was all rejected. He had a very cold review saying that that's probably not TB causing the illness, and he was pretty upset about it. But later on, there was wider recognition, and actually after his discovery and following his discovery, and Dr. Robert Koch made a huge success in terms of discovering the Koch bacillus. So he wrote a pretty bitter letter to the Pasteur saying that I suffer a certain amount of distress in thinking that the leading scientific academy still gives at least a sort of toleration to my former enemy. So that was then when the French and German war was happening, and then the Germans actually won over the French. Koch's bacillus, of which Germans are so proud, has obscured the memory of what the French scientists had already accomplished. So gotta give due credit to Dr. Villemin, right? Before Robert Koch. And of course, Dr. Robert Koch in 1800 discovered the TB bacilli. He won the Nobel Prize in medicine in 1905, and this discovery was a pivotal step in the fight against tuberculosis. So some basic facts of tuberculosis, and the audience you can just chime in, throw in all the numbers. What was the number of deaths in 2017 due to TB? It's pretty big. Worldwide. 7 million. 1.3 million. What was the TB incidence worldwide in 2017? Pretty big number again. 10 million. And 2/3 of cases of those 10 million cases are from these countries. Name some of them. India, China. Okay. The top 3: India, China, Indonesia, Philippines, Pakistan, Nigeria, Bangladesh, and South Africa. And how many % of the world's population is suspected to have been infected with latent TB? 10, 15? 23% of the world's population, or 1.7 billion patients, are affected with latent TB worldwide. Just a little bit more facts. How many cases of rifampin-resistant TB cases that we know of? About 500,000, and 82% of these cases are actually MDR-TB. And effective drug regimens have been available since the 1940s. And how many people treated and cured since 2000 to 2017? Guesses? 54 million people. 54 million people. And TB is the nth leading cause of mortality from a single infectious agent next to HIV. It's the first, right? And among all these documented TB cases, how many patients had actually documented HIV test result? Only 60% in 2017. Okay. So what is our struggle? What is the why are we still talking about tuberculosis? Why haven't we actually conquered tuberculosis? So it runs on mainly underdiagnosis and underreporting of detected cases. And those are the top two reason why is mainly because there is lack of access to care. And mostly, as we've seen, the majority of these patients are from developing countries, so they have a lot of issues with access to care, gaps in detection, and the treatment of MDR-TB and HIV-associated TB. Here, in the past, they used to have these little animation in newspapers. Benny the Bug scores another cavity, and crowd is going wild. Okay. So the WHO had proposed a very ambitious strategy to end TB. So the main goals to end TB by 2035 is to reduce the number of TB deaths by 95%, reduction in TB incidence rate by 90%, and there should be nobody and no families affected catastrophic costs just to get care and the treatment for tuberculosis. So this end TB strategy is met with 3 pillars, mainly on the first pillar focusing on patient-centered care and prevention through early diagnosis, treatment available for everyone, and preventative strategies. Second pillar consisting of bold policies and supportive systems, political commitment, social protection, and more really global kind of tackle on the issue. And lastly, which we're going to talk about, is intensified research and innovation, mainly on discovery and development of new tools, new diagnostics, new therapeutics. Okay. So our delay really in reaching prompt eradication of TB relative to the development of these groundbreaking diagnostics and therapeutics, warrant a synopsis of our current strategy towards the fight against TB. Okay. So the WHO, this is from again WHO 2017 paper. They classified some of the diagnostics that are in pipeline into 3 complexity: high complexity, moderate complexity, and low complexity. So we're going to talk about some of them today. So with high complexity, some of these tools we are already using, like the PCR machine that is available here, Mycobacterium PCR. And these are the molecular tests. This is a moderate complexity test. On top we have molecular detection, and then the gene expert. The first thing that we're going to talk about is the Alere Q. It's actually a point of care urine test for tuberculosis that's being developed. The quantiferin test we are already using. The e-nose or electronic nose to detect tuberculosis in different samples. And the CAD or the computer-assisted diagnosis on imaging. And lastly, fluorescent microscopy. It's basically trying to lit up the Mycobacterium bacillus for detection, easy detection and quick. And low complexity, lastly, we're going to talk about this cell wall antigen that's present in Mycobacterium cell wall. Okay. So again, bulk of my talk is going to be on artificial intelligence. So artificial intelligence was first described in 1955 as the science and engineering of making intelligent machines. So the AI uses or solves complex mathematical problems, and they turn it into a novel solutions in complex challenges. And it is already being widely used in the field of military, security, transport, manufacturing, and of course in medicine. Machine learning is an application of AI where the machine uses mathematical algorithms to learn, and learning by the AI is improved through experience. And experience here actually means the vast amount of data that is already available to kind of teach the AI. We're going to talk about artificial neural network, which is a tool in AI which processes information through highly interconnected processing elements in response to external inputs. And ANN is basically a tool that is used to analyze and process data and give out novel solutions to complex questions. It is being used in discovering novel therapeutic targets, examples like proteins and different kinds of molecules for novel therapeutic targets, risks for chronic disease such as diabetes, and emotional disturbances with psychiatric conditions, and also those robots that's being used in surgery. So I'm going to give you an example because I see this blank stare on everybody's face. It's like, what are you talking about? So ANN is basically like a human brain, okay? So that's how they modeled it after. So on top is the basic anatomy of our neurons. So when the neuron receives information from your dendrites and passes it along to other neurons through your axon, right? So this is the basic setup of ANN. You have an input layer where you received information. These are the neurons that receive information. They would pass it along to the next layer, which is called a hidden layer, and you can have as many hidden layers as you can. These hidden layers, when they receive the information from the input layer, and all of these are numbers and mathematically processed. So each information is assigned a weight. So let's say first information, let's say cough. Cough is multiplied with a number, let's say 5, and then that's processed through the hidden layer, and all of those information would be transferred to an output layer, and then it will come up with a solution after passing through a certain threshold. Okay. So this, again, some technical definitions we have to go through. So neuron, like I talked about, is an information processing artificial nodes. Input layer is the layer that receives information, passes it along to the hidden layers that helps process the information, and ultimately to the output layer that contains classifications or interpretations of the neural network. Weights are initially assigned to determine the strength of those connections, and it can be changed later on after some training and learning by the AI. And training an ANN, which we will talk about, is the procedure to reassign those weight values to come up with a correct solution. Okay, and then learning is adaptation. Okay, so you know how in Facebook, when you take a picture, stuff comes up, oh, this is like your face, the Facebook recognizes your face, the face recognition pattern. When I first saw that, I freaked out. I was like, how do you know my face, or like my friend's face? So that's basically Facebook using artificial neural networks. So at first, when you see on top, and this is just an example, so let's say, let's train a Facebook. So we're gonna feed the ANN with multiple pictures of correct pictures of, let's say, dogs, cats, chickens, rabbits, all different types of animals, right? And we have already trained the ANN to correctly categorize which picture is which, right? And then so it is ready to go. So we're going to test it. So we're going to feed this ANN an unknown or unlabeled image of, let's say, a dog. So then through the first layer, it will try to analyze certain parts of this picture. Let's say, okay, this is a tail part, this is a nose part. And it will be processed through different layers again, right? Those hidden layers with assigned weights, and it will recognize, okay, this part is a nose, that's important. This part is a paw, that's important. And it'll be, and with predetermined weights, because the ANN has already been trained, ultimately it'll give you an output that this is a 90% dog picture. Okay? Is everybody yes with me? Yes, I still have the blank stare. Okay. One last example. So this is actually the complicated mathematical equation. I'm not going to talk about this, but let's cover it up. So let's say we are making an ANN to diagnose somebody with tuberculosis. Wouldn't that be cool, right? So maybe replace doctor. No, just kidding. Replace doctor someday by AI, so, right? So under supervised training, right? So let's say, so the ANN is capable of processing really a vast amount of data, right? So which is already available, right? Just look at our Epic. You know, we have tens and thousands of patients. We have 58 million patients who have been treated, right, for tuberculosis since 2017. So imagine using all of those data and all of their information. So let's say for the inputs, we're gonna put their symptoms, right? They have patients coming in with cough, patients coming in with weight loss, HIV status, fatigue, all these different types of symptoms. We put them. And then initially we can assign certain weights to them. Let's say, and this is just an imaginary number, right? Cough, if you're coughing a lot, let's say for 2 weeks, that's a heavy weight, right? 5. Weight loss, 4. HIV, 3. And then it will be processed through the ANN, and still under supervised training, you set a threshold, right? Because we know this set of patients have TB or no TB. So the threshold is this patient has TB. And if the ANN gets it correct, then that's good. Then the ANN will remember these type of weights. If it gets it wrong, then what happens is it'll go back through unsupervised training. It'll alter those weights and rerun it until it gets it right. Change the weights until it gets the correct diagnosis of tuberculosis. Okay? All right. So again, the ability of ANN is to recognize even untrained patterns and remember all of these vast amounts of data. Whatever you put in there, it will not forget. Okay. So again, with that concept in mind, this ANN is being used in the detection of Mycobacterium tuberculosis in terms of smear microscopy and your electric nose, and in diagnosis of pleural effusions and imaging. Okay. So with sputum smear microscopy. So what is a sputum microscopy? This technique was actually developed over 100 years ago. So we're using still this similar technique that was developed over a century ago. And it could be a pretty daunting and arduous and a time-consuming task for pathologists, because and they have to view this in a 1,000 times high-power view. So this is gram-negative rod bacilli. It's very tiny bacilli that you have to look through at different parts of the slide, which has been very magnified, right? So just to have an idea how small this is, the round purple is a human hair, and this is the tubercle bacilli is 2 nanometers. It's very tiny, right? So then, how can we use the AI for smear microscopy? So the scientists, and this is a study from China, already developed this ANN and trained this ANN with 3 million samples. 3 million samples of basically photos and pictures of these purple red thin rods, acid fast staining, and predetermined by pathologists as, okay, this is tubercle bacilli, this is not tubercle bacilli, this is a dye residue, etc. So they've already trained this ANN with 3 million samples. the sensitivity and specificity they were able to achieve was pretty high, so 97.9% and specificity of 84.7%. The main limitation of this ANN was determining a contaminant versus a pathogenic bacilli. And ultimately, they concluded that this technology could actually help the pathologist, not necessarily replace the pathologist, but help them kind of go through many different samples at a faster rate. So what do you see here? So this was an image that was actually missed by the computer, by the AI, but that was the pathologist actually concluded that this was a pathogenic bacilli because it was already surrounded by some necrotic tissue, right? Other one, the AI actually labeled this as a bacilli, but it was wrong. It was actually a dye residue. Other example, so the AI for this one labeled this as a pathogenic bacilli, but the pathologist actually said this is not a pathogenic bacilli because it's actually not surrounded by necrotic tissue. There's no evidence of caseating necrosis. So these are some of the limitations by this particular ANN. And you can't really see anything here. It's a poor quality smear. Okay, moving on to electronic nose. So this is a handheld device that was developed by a company in Netherlands. You blow, the patients blow into it, as you can see with the nose clip. There's no need for specialists. There's no need for respiratory therapists. There's no need for big hospital. It takes less than 10 minutes for the machine to pick up the scent or the volatile organic compounds through this filter, right? And this will be used, because this is still early in the development, this will be used in early diagnosis of cardiovascular diseases. So this is being looked into cardiovascular diseases, chronic obstructive lung disease, asthma, urinary tract infections, wound infections, breast and lung cancer. So how do we smell? So again, very similar to how the human brain works, right? So the initial smell is picked up through the nasal passageways, is processed through the brain, and then the neurons pick up the signals, and then we recognize it as a Brazilian coffee for this picture. So similar concept with the electronic nose. So the raw signals is passed through, again, the ANN system, the input layer, hidden layer, through the neural network, and the pattern of those volatile compound is picked up as such and recognized as Brazilian coffee. So this particular study and this particular device, they used all of these different modalities, like say age, height, weight, body mass index, some lab numbers and symptoms of the patient. And importantly, they also fed into the ANN system the results of sputum microscopy, culture, chest x-ray results, tuberculosis, open, close, whether it was a new diagnosis, relapse, or latent TB. So what did they find? So they found a sensitivity of 93.5% and a specificity of 85.3% in discriminating healthy controls from TB patients. And the authors actually conclude that, and this was a study in Bangladesh after a validation study of 194 patients, they actually concluded that they may, through this machine, they may actually increase the detection of prevalence by up to 300 to 400%. Mainly because it's so easy to use. It's a handheld device, takes only 10 minutes. Again, there's no need for specialists, special pathologists, or a hospital setting. And and this can easily be used in a rural setting where resources are limited, right? The main limitation of the study is the quality of initial training set and gold standard. So I'm going to ask Dr. Casañas, what is the gold standard in diagnosing tuberculosis?
It's still the culture.
There is, culture, but you still said it could be missed by culture. So there's not really a gold standard for diagnosis of tuberculosis.
Such a sensitivity and specificity.
Yes, which just affects sensitivity and specificity. This was another study done in Egypt. This was actually a different device, but kind of similar concept of electronic nose. For this device, they tested 260 patients who have been newly diagnosed with tuberculosis, and they matched it with 240 healthy individuals. This study was done in Egypt. So they took samples of these patients, blood sample, urine, breath, and sputum samples. And they measured the odors of volatile organic compounds in the headspace. So the headspace means, let's say in a test tube, you have that sample over there. It's not directly smelling the sample itself, but it's the odor or the compounds that are present just above that sample, right? And through a system, they send it through a chip that is embedded with the ANN. They were able to achieve really, again, great sensitivity, more than 95, specifically in blood, breath, and urine sample, and very high specificity. And again, their conclusion was, again, obviously more research have to be done, but they emphasized on potentially very low cost and mass screening. Again, this is not a big device. It's a small chip that you can just kind of test the samples, and also used for early detection.
I have a question for both the slides. So given that there is such a high rate of infections, right? Not everybody manifests the symptoms.
Mm-hmm.
How are they detecting the difference between people who are infected and those who are infectious? What would be the challenge? I mean, if
That's
you
still
that somebody would have to,
right.
the compounds would have to have a different smell if you are infected versus those who are
Right.
infectious.
Right. So that's still a question to be answered. Yeah, that wasn't specifically addressed yet.
And with these two specimens, what if they had non-pulmonary TB, especially with the first
Right.
one where you blow?
Right.
where you blow
Again,
it?
not commented yet. Still to be yet to be discovered. Yeah. And we have a test for pulmonary and extrapulmonary later on that addresses that question. Yeah. Okay, so what about diagnosing TB pleural effusion? As we know, well, no gold standard unless maybe we get a chunk of that pleural tissue and send it for culture, which is very invasive. The current tests we have, the nucleic acid amplification, is again very high specificity but kind of lower sensitivity. Again, pleural biopsy may be ultimately be needed to establish diagnosis, but again, with that, there's only 80% sensitivity. Some of the biomarkers that we're using right now, right, is adenosine deaminase and interferon gamma, but it could be non-specific, and also it could not be available in rural areas or underdeveloped countries. And early diagnosis of TB pleural effusion is obviously imperative to reduce complication of TB empyema, fibrosis, or even progression to pulmonary TB. So AI used in TB pleural effusion for this particular study. This study was done in Brazil. They studied 135 patients, and 96 patients had pulmonary TB. They included factors such as age, 10 symptoms they didn't really elaborate on, smoking status. They included classical tests. So these patients have already been undergone pleural biopsy. That's why they had the histopathology, pleural fluid tissue culture, fluid culture, AFB, and HIV status. And they did include the adenosine deaminase test, ELISA, and nucleic acid amplification test. So what did they find? So with this particular test, again, they were able to increase the pretest probability from 70% to more than 90%, and this was done among HIV patients who were co-infected. And their conclusion of the study is, with this technology, maybe we could avoid the pleural biopsy. Maybe we'll have enough post-test probability, pretest probability to just go ahead and treat and not go through the invasive procedure. And this could actually be developed on a mobile phone or a tablet without the use of internet. And of course, the limitation of the study, low number of controls, which questions, then there should be a question on specificity, and again, lack of gold standard. Okay. AI in imaging. So this concept of using artificial intelligence predates the technology itself. So it was first described in 1967 in the journal Radiology. A computer was used to highlight the differences in optical densities of mammogram films produced by a fax scanner. So from then till now, we have obviously a better imaging, right? The digital imaging. This is more efficient. The quality is much, much better than a fax machine. It's readily available in areas with computers. Has low operation costs, and it's safe because it uses a more efficient plate, which means less radiation for patient. And once the image is loaded into packs, the image could be brightened, intensified, stretched, etc. So computer-aided programs in imaging is already being widely used in mammography, lung cancer screening, but it does have pretty high false positive rates. It's not quite there yet in terms of distinguishing, let's say, tuberculoma from a lung cancer. So the existing technology we have, looking into chest X-ray, right? Chest X-ray currently we need that to rule out active TB in patients living with HIV on ART, and patients who are less than 5 years of age. So the accuracy of these chest X-ray depend on the experience of the radiologist, experienced radiologist and technician, and the imaging equipment available, which could be very variable in different areas. So, and this AI and this technology could be used again, right, in areas with limited radiologists in the rural area. So the computer-aided diagnosis is a standardized technique, unlike different radiologists reading the same X-ray differently. And our current technology that exists achieves a sensitivity greater than 85%. Some papers say it's better than radiologists, but the specificity is actually still pretty low. And this is due to the discrepancies in terms of burden of patients with TB and HIV. There were a lot of patients who were lost to follow-up, and there have been minimal data on age, HIV, gender, and a history of active TB. AI in drug discovery. So this particular study was looking into 18,606 molecules to basically feed it into different types of ANN and different machine learning methods to potentially predict a molecule that would be that could be prioritized into actual drug development. So this is in the process of discovery. Again, we're kind of going back to that the pillars and then the WHO global investment page. We talked about mostly of artificial intelligence, and we're going to talk about some point of care testing, a urine test, Alere. We talked about the eNOS, we talked about the CAD, and we're going to talk about fluorescent microscopy. So point of care molecular test is kind of your next big, I should say, technology that's in the pipeline that's very promising due to the speed and low cost and ease of use for applications. And it's they're using very high sensitivity molecular tests, and these are some of the point of care molecular tests that we are already using, right? So the Alere group developed this point of care urine test. So this is how the test strip looks like. It's about probably finger big. So what it's detecting is your lipoarabinomannan antigen, and this LAM, in short, LAM, is actually present on the outer cell wall of MTB, Mycobacterium tuberculosis. It is processed and it's filtered out among metabolically active or degrading cells. And it's actually detectable in the urine, unfiltered urine. This only takes 25 minutes, and this test was actually studied among HIV patients, which is even better, regardless of CD4 count. So unfiltered urine, HIV patients, regardless of CD4 count. So you just the patients just pee into this strip. And this test strip was actually developed to diagnose both pulmonary and extrapulmonary TB, because again, this antigens from wherever it comes from, it's filtered through the kidney and comes out. So you can diagnose both potentially. No sputum is required, so again, an advantage for any patients who cannot produce sputum. And they say this test strip could be used in conjunction with microscopy and PCR expert to increase your yield for diagnosis. And this achieved pretty high sensitivity and specificity, but they couldn't really say much about it because, again, this is still very early in the development. And this also potentially provides same-day treatment for high-risk patients. Microfluidics is a molecular test. It's a lateral flow immunoassay, so this is the fluorescent microscopy. So this particular molecule that they developed allows for rapid labeling and detecting live bacterium in 1 hour. So to your left upper hand corner, so this molecule will be processed through this native enzyme called BLAC, BLAC, and DPRE1, which is only present in Mycobacterium tuberculosis and BCG, not in among those 43 species of NTM. So it's pretty cool. So it's very specific for MTB. So and this only detects live bacterium, not the dead bacterium, because it needs these enzymes to quote unquote lit up and be trapped in the cell membrane of MTB and kind of stay lit up. So again, this is potentially could be developed into a point of care test strip, and it will be low cost and processed through a self-driven microfluidic chip. So I know this looks complicated, but basically it just uses a very small sample, run it through the test strip, and it'll basically light up and then picked up by your LED, and then on a test strip, if it's positive, it'll just light up, and then you know live Mycobacterium is there. So in conclusion, so we have a lot of promising technology of artificial intelligence in terms of detection of TB and microscopy, both ways, sputum smear and fluorescent, reading normal radiographs, your computer-aided diagnosis, clinical algorithms like your diagnosing tuberculosis, pleural effusions, and potentially looking for target compounds for drug development, and some of the molecular tests. And that is it. Thank you very much.